Hi, everybody. I'm here with Dr. Joseph Goldberg, who's professor of psychiatry at the Icahn School of Medicine in New York and a leading expert on the topics of bipolar disorder and on adverse effects of medication. Dr. Goldberg, why is the depressed phase of bipolar disorder so much more problematic than maybe other aspects of treating bipolar disorder?
Well, a few things. You mentioned the depressed phase. So what's fascinating about bipolar illness is that it's non-static. It's a moving target. And patients will have variations from one mood state to another. So rather than in the case of unipolar disorder, where we can hone in on just the depression, almost irrespective of what's flanking it, in bipolar disorder, we're as much interested in the inflection points. That is, you go down, then you come up, then do you overshoot, and how much time do you spend with your slope of your mood. Let's say if you were crafting a mood chart, how often is your slope at zero even? Very little time spent if we do mood charting with patients. So we're not just treating the depression, we're really treating the change factor that seems especially distinct in bipolar disorder. So one aspect is the non-static nature of mood change.
Okay.
Second aspect, and recurrence, which goes alongside. A second aspect is that it appears to be that the depressed phases of this illness are just harder to treat. There's never really been very compelling research that antidepressants are efficacious for the depressed phase of bipolar illness, at least for the antidepressants that have been studied, which is a minority of the existing pharmacopoeia of antidepressants. Most have not been studied in bipolar depression, but of those that have, there's very little compelling research to say that substantial effects can be seen. So that's very frustrating, because if depression is the dominant mood state that we see in bipolar disorder, or time spent with mood symptoms tends to occupy depression more than mania or hypomania, we don't really have excellent treatments. No one's ever shown that an antidepressant, for example, is better than a sugar pill, or better than a mood stabilizer for treating the depressed phase of bipolar disorder. And then the last piece, I would say, is the concern that antidepressants have the possibility of either inducing the next phase of illness, a mania or a hypomania, or accelerating the frequency of cycling over time. And while I think most clinicians are aware of or familiar with or think about the risk of antidepressants inducing mania, the literature would say that that is a risk, but it's a much lower risk than many people think. It's probably more like 10 to 15% of bipolar patients who will have a destabilization of mood with an antidepressant. The biggest risk is lack of efficacy. And so here's the dilemma, is we don't have a lot of treatments that work for the depressed phase.
Yeah.